Donc, on va commencer ce débat par 4 exposés introductifs. Le premier, donc, qui sera présenté par Ivana OBRADOVIC, qui, je le rappelle, est directrice adjointe de l'Observatoire français des drogues et des toxicomanies, et donc qui va nous brosser un tableau des addictions en France au temps du confinement. Voilà. Ensuite, Joan COLOM parlera, lui, de l'impact du Covid-19 sur le bien-être émotionnel et sur les addictions à partir de l'expérience de la Catalogne. Enfin, non pas enfin, mais ensuite, Steffanie STRATHDEE de San Diego, qui est déjà venue à Biarritz, mais qui, du fait du Covid, n'a pas pu nous rejoindre comme elle le prévoyait cette année, et qui interviendra donc en visio. Et enfin, le regard de la sociologue, Marie-JAUFFRET-ROUSTIDE nous parlera du Covid, de l'usage de drogue, de réduction des risques dans une perspective internationale. Voilà. Et ensuite, pour le débat, donc je remercie de nous avoir rejoints Jean-Michel DeLille, le docteur Jean-Michel DeLille, qui est le directeur général du CEIT de Bordeaux, et qui est aussi le président de la Fédération Addiction. Donc il a beaucoup de casquettes, beaucoup de titres, et il en a un autre, c'est que c'est un ami et qu'il est un fidèle des ATHS depuis le début, auquel il participe activement. Voilà, donc Nicolas Bonnet, qui est aussi un ami, qui connaît aussi THS et qui est donc le directeur du RESPADD, et donc qui a aussi travaillé, réfléchi sur ces problèmes à l'occasion de cette épidémie de Covid. Voilà. Amine BENYAMINA, bien sûr, devrait être là, mais il arrive, alors on ne sait pas quand, voilà, d'ici la fin, au moment du débat ou non. Donc Amine BENYAMINA, qui est aussi nos amis, qui est président de la Fédération française d'Addictologie. Et il me rappelait donc le temps qu'il arrive, je peux le remplacer puisque je suis au bureau de cette FFA. Et donc voilà, donc sans plus attendre, on va donner la parole à Ivana pour initier cette séance de présentation, qui sont des exposés, je rappelle, introductifs, pour permettre un débat après avec le plateau et avec la salle. Ivana, la parole.
Bonjour à toutes et à tous. Donc pour introduire ce débat sur les drogues et les addictions au temps du confinement, je vais vous faire une petite synthèse de ce qui s'est passé en matière d'offres et de demande de drogue et de risques d'addiction pendant la crise sanitaire liée à la pandémie de Covid-19, en particulier pendant les 3 confinements. Alors pourquoi ce focus ? Comme vous le savez, depuis le premier confinement, un certain nombre de mesures exceptionnelles ont été prises. Restrictions de circulation qui sont allées d'un couvre-feu jusqu'à l'assignation à domicile de la quasi-totalité de la population, la fermeture des frontières, la fermeture des écoles, la systématisation du télétravail. Ces mesures, elles ont pesé sur les habitudes de vie et de circulation en France et à l'étranger, sur les pratiques de sociabilité, avec la fermeture des bars et des restaurants qui a entravé les sorties le soir, l'organisation du travail également, avec des contraintes de présence à domicile et en famille. Bref, autant de facteurs qui sont associés, on le sait, au comportement d'usage et aux addictions. On pouvait donc faire l'hypothèse d'un effet propre du confinement sur la situation des addictions, dès lors qu'ils perturbent à la fois les contextes d'approvisionnement et d'accès aux produits, mais aussi les contextes d'usage de drogue, avec la suspension des occasions festives, par exemple, et finalement les comportements d'usage eux-mêmes. On sait par ailleurs, grâce à la littérature, que l'anxiété, l'isolement, les situations de contrainte tendent à aggraver les vulnérabilités et les risques de survenue et d'aggravation des addictions. Alors, pour répondre à toutes les interrogations qui ont pu émerger dans cette période d'incertitude, il y a une profusion d'enquêtes qui ont été lancées dans l'urgence, avec souvent des financements exceptionnels qui, pour une grande partie d'entre elles, sont toujours en cours. Donc, en attendant, je vais revenir sur quelques tendances qui se dégagent sur deux aspects, l'offre et les marchés de produits illicites, en particulier la consommation de produits, en tout cas pour les trois produits les plus consommés, donc tabac, alcool, cannabis, mais aussi pour ce qu'il est coutume d'appeler une addiction sans produit, les jeux d'argent et de hasard. Alors pour cela, je vais mobiliser principalement des données issues de la statistique publique, notamment l'enquête en 15 vagues qui a été mise en place par Santé publique France dès la deuxième semaine de confinement, dont 5 vagues sur 15 ont mesuré la consommation d'alcool et de tabac, mais aussi plusieurs sources de première main, à commencer par les observations directes qui nous sont remontées par le dispositif TREND de l'OFDT, Tendance récente et nouvelles drogues, qui repose en partie sur les professionnels sociosanitaires et médicaux qui travaillent dans l'Exapa et les CARUD, dans les sites de Lille, Metz, Lyon, Marseille, Toulouse, Bordeaux, Rennes et Paris. Et j'en profite pour les remercier tous pour ces remontées. Je vais mobiliser également les signaux du dispositif Synthèse, qui est un dispositif de collecte de produits en lien avec des laboratoires d'analyse de la police et des douanes, qui nous permet d'avoir un suivi de la composition des produits qui circulent sur le marché. Il y aura d'ailleurs jeudi, je crois, à 14h30, un atelier sur l'analyse de drogue où ce dispositif sera présenté parmi d'autres. Troisième type de source, une enquête par questionnaire qu'on a menée en ligne auprès des consommateurs de cannabis rétrospectivement pendant l'été qui a suivi le premier confinement. Donc c'est l'enquête cannabis online de l'OFDT. Et puis j'ajouterai aussi quelques données officielles, notamment celle de l'autorité de régulation des jeux, l'ANJ, qui a été créée en 2020 pour remplacer l'ARGEL. J'en dirai pas plus sur les détails de méthode, puisque vous pouvez trouver la synthèse de tout ce que je vais présenter sur le site de l'OFDT, dans le numéro 139 de la revue Tendance. Et donc, je vais m'en tenir ici aux quelques tendances observables qui ressortent, autour de deux questions en particulier. D'abord, dans quelle mesure le confinement général a engendré une contraction de l'offre de drogue ? Et est-ce que les restrictions d'accès ont joué de la même manière selon les produits? Et puis, comment les pratiques d'usage ont évolué compte tenu du changement des modes de vie en journée, avec le recours systématique au travail à domicile, mais également en soirée, avec l'interruption des sorties, la fermeture des bars et des restaurants, l'annulation des événements festifs, l'annulation aussi des compétitions sportives qui ont signé l'arrêt des soirées foot, par exemple. Alors pour des produits illicites comme l'alcool et le tabac, l'accessibilité est restée forte. Vous avez ici sur la courbe ce qui s'est passé pendant le premier confinement, par comparaison avec la courbe en pointillé qui est celle de 2019. Donc ici, vous avez le détail mois après mois. Sur les ventes de tabac qui sont en violet en haut, les ventes d'alcool avec des sources de la Direction générale des douanes et des droits indirects. Donc vous voyez que si on regarde uniquement les volumes de vente, l'offre d'alcool et de tabac a été relativement peu altérée par le confinement, puisqu'il n'y a pas de décrochage majeur sur les courbes, mais néanmoins, il y a quand même quelques ruptures de tendance, selon un schéma qui est commun d'ailleurs pour le tabac et l'alcool, en 3 temps. D'abord, une différenciation par rapport à la courbe de 2019 dans le premier temps du confinement, c'est-à-dire en mars-avril. Ensuite, une stabilisation en avril-mai. Et puis un rebond en sortie de confinement qui est plus marqué pour le tabac que pour l'alcool. Alors il y a aussi des spécificités, par exemple sur le tabac qu'on voit ici en violet. Il y a eu un regain des volumes de vente pendant la durée du confinement, avec une hausse de 24% d'un mois sur l'autre entre mars et avril, ce qui était du jamais vu depuis 10 ans, au point de dépasser les niveaux de 2019. Alors ce rebond, on peut l'interpréter de 3 manières. D'abord comme un indicateur de motivation des fumeurs à s'approvisionner en cigarettes. Ensuite comme un indicateur de capacité effective à s'achalander en tabac. Mais aussi en partie comme un réflexe de stockage de cigarettes, ce que certains médias ont appelé l'hamstérisation. En tout cas, il y a eu une rupture avec la baisse des ventes de tabac qui était observée depuis plusieurs années, qui laissait craindre une recrudescence du tabagisme. Alors, 2 précisions qui ne sont pas sur cette courbe. D'abord, la hausse qu'on voit sur le tabac elle est 2 fois plus marquée pour le tabac à rouler que pour les cigarettes manufacturées. Et puis, deuxième point, c'est une hausse qui est territorialement ciblée, c'est-à-dire qu'on a eu pendant le confinement plus 25% de ventes dans les départements frontaliers, ce qui correspond en fait au volume habituel d'achat à l'étranger, au Luxembourg ou en Espagne, qui ont été mis à l'arrêt de fait avec la fermeture des frontières. Donc en fait, cette hausse, elle traduit plus un transfert des achats vers le réseau des buralistes qui s'est trouvé de fait en monopole qu'une hausse des consommations en tant que telle. Sur l'alcool, qui est en bleu, vous voyez qu'on a une évolution contraire à celle du tabac dans le premier temps du confinement, avec des ventes qui fléchissent par rapport à 2019. Il faut préciser quand même que cette baisse, elle est ciblée sur quelques types d'alcool, surtout les vins, les champagnes, les bières, bref, les alcools plutôt festifs. Et la baisse a été moins nette pour les spiritueux. Donc globalement, ce qu'on peut dire, c'est que l'offre s'est maintenue dans les toutes premières semaines du confinement, surtout pour le tabac. L'explication, c'est que si le tabac et l'alcool ont fait l'objet d'un soutien public en étant classés en commerce de détail alimentaire et sont restés ouverts, puisqu'ils étaient considérés comme des biens de première nécessité, le tabac a en plus bénéficié d'un soutien privé. C'est-à-dire que les buralistes ont reçu l'appui des 4 grands fabricants présents sur le marché, qu'on appelle les Big Four, qui ont pris en charge tous les coûts d'équipement des bureaux de tabac, en matériel de sécurisation des transactions d'achat, les vitres et les protections de comptoirs en plexiglas, les masques, les brouettes de gants, le ruban adhésif pour le marquage au sol, pour faire respecter les distances. Donc c'est une différence qu'on peut expliquer comme ça. Alors, est-ce que ces tendances ont été similaires pendant le deuxième confinement? On voit ici que ça n'a pas été le cas pour le tabac, puisqu'on a vu au contraire un décrochage des ventes très marqué au début de la période de confinement, puis une reprise à la hausse jusqu'à dépasser les niveaux de 2019. À l'inverse, sur l'alcool, on a vu à nouveau une baisse des ventes pendant le confinement, puis une reprise progressive. En revanche, quand on compare la situation du tabac et de l'alcool, on voit que les tendances sont assez uniformes à la sortie du premier confinement, avec une nouvelle envolée du tabac à partir de la mi-mai 2020, qui pouvait laisser craindre une reprise du tabagisme après plusieurs années de bons résultats. Mais finalement, ce regain il a été éphémère, puisque vous voyez que les courbes finissent par se superposer. Et sur l'alcool, on a une hausse régulière avec la levée du confinement, jusqu'à un pic en août, bien supérieur à l'été 2019, et des niveaux de vente d'alcool qui, par la suite, se sont maintenus au niveau de 2019. Donc, pour conclure là-dessus, on peut dire qu'il y a clairement eu un effet de rattrapage sur l'alcool, avec certes des variations saisonnières, mais qui sont habituelles toutes les années, et qui ont été particulièrement élevées à l'été 2020. Enfin, au moment du troisième confinement, qui était le moins long des 3, comme vous le savez, moins d'1 mois, les ventes d'alcool qui sont en bleu ont tout de suite surclassé les ventes de 2019 et ont continué à progresser avec le déconfinement par rapport à 2019. Donc au final, ce qu'il faut retenir de cette première série de diapos, c'est que la crise sanitaire et les confinements successifs n'ont pas endigué le recul du tabagisme, mais ils sont allés de pair avec une intensification de la circulation d'alcool, en tout cas telle qu'elle est mesurée par les ventes. Alors en matière de drogues illicites maintenant, comme on pouvait s'y attendre, les routes du trafic, les voies d'acheminement et le trafic de rue ont été perturbées. Si on regarde l'indicateur du volume des saisies, qu'on considère comme un indicateur de circulation et de disponibilité des produits, on voit que le niveau des saisies a été affecté à la baisse par le confinement. Il y a une exception quand même, c'est l'héroïne, avec une légère hausse même, c'est-à-dire qu'en 2020, on était à plus d'1 tonne d'héroïne saisie, ce qui s'explique par, en pratique, pendant la période du confinement, un ciblage des usagers et des petits trafiquants, puisque 6 saisies sur 10 concernaient de très petites quantités d'héroïne. Pour la cocaïne, on a des saisies, enfin des volumes de saisies qui sont en baisse, hein, comme pour tous les autres produits illicites, sauf l'héroïne, donc. Mais malgré tout, c'est resté très élevé en 2001, avec plus de 13 tonnes de cocaïne saisie, soit une quantité supérieure à 10 tonnes pour la 4e année consécutive. Et on a pu voir aussi que l'acheminement par la voie maritime avait continué à prendre de l'ampleur. Pour le cannabis, qui est la principale drogue illicite consommée en population générale, comme vous le savez, les saisies ont marqué le pas. C'est-à-dire qu'on pouvait imaginer un effondrement du marché s'agissant d'un produit illicite qui est vendu le plus souvent sous forme de trafic de rue. Eh bien, ça n'a pas été le cas, puisque l'offre est restée assez présente et accessible, même si, effectivement, la disponibilité du cannabis a connu un certain recul au regard de la baisse des saisies. Vous le voyez ici avec un seul chiffre comparant mars 2020 à mars 2019. Et même si les points de vente physiques se sont raréfiés, ce sont surtout les modalités du trafic qui se sont transformées, avec une intensification des livraisons à domicile, qui est une tendance qu'on observe depuis les années 2010, mais qui s'est encore intensifiée pendant le confinement, et un plus grand recours aux commandes par SMS et via les réseaux sociaux. Donc il y a bien eu une baisse des achats et des transactions, mais l'évolution marquante, c'est surtout le recours à d'autres sources d'approvisionnement, en particulier l'autoproduction de cannabis ou le don de cannabis cultivé à domicile. En termes de composition du cannabis en circulation, ce que nous remonte le dispositif synthèse, c'est que pour faire durer les stocks, le cannabis qui a été mis sur le marché a été davantage coupé. Et au-delà du cannabis, la teneur et la pureté des produits qui ont été vendus ont été largement revus à la baisse. Il y a eu plus d'arnaques, plus de tromperies sur la marchandise, plus de pratiques d'adultération. Donc il y a bien eu des ajustements de l'offre, mais pas de pénurie importante et durable, en tout cas sur l'herbe. Sur la résine, néanmoins, il y a eu une pénurie temporaire, s'agissant d'un produit importé, et c'est d'ailleurs une pénurie qu'on observe dans d'autres pays européens, par exemple la Suisse. Cette rupture d'offre, elle est aussi confirmée par d'autres indicateurs, comme la hausse du prix de vente au détail de la résine, c'est-à-dire que le gramme de hashish est passé de 5,70 € à 7,20 € pendant le confinement, donc une hausse de plus d'un quart. Bref, ce qu'il faut retenir, c'est qu'il y a eu plus de perturbations des marchés illicites que des marchés légaux, du point de vue de l'offre et des volumes disponibles. Et cette contraction de l'offre, elle est allée de pair avec une restructuration du marché du cannabis. Alors on le voit ici, c'est une restructuration qui n'a pas été brutale, qui ne date pas du confinement, mais qui a été accélérée dans cette période, avec l'affirmation de la place de l'herbe dans l'offre de cannabis. Vous voyez qu'on a une baisse générale tendancielle de la résine dans les volumes de saisie, mais malgré tout, en 2020, c'est la première année où on a presque autant de volumes de saisie d'herbe que de résine. Et surtout, quand on regarde la part de l'herbe dans l'ensemble des volumes saisis en matière de cannabis, elle était de 29% en 2019, elle est de 48% en 2020, donc vous voyez que c'est une hausse qui est très conséquente, et ça représente désormais près de la moitié du marché du cannabis, qui est tout à fait inédit. C'est confirmé aussi par le nombre de pieds saisis qui reste à un niveau élevé, même si 2020 n'est pas une année record, ce qui confirme la présence de la cannabiculture en France. Autrement dit, la disponibilité du cannabis produit localement a augmenté pendant les confinements, en Europe comme en France, et en France en particulier dans certains territoires comme les Outre-mer ou les Hauts-de-France par exemple. Alors qu'est-ce qu'il en est maintenant des pratiques d'usage déclarées ? Il faut d'abord préciser que dans les dispositifs statistiques, il y a eu plus de mesures, dans un premier temps, des quantités consommées que des prévalences d'usage, parce que les enquêtes épidémiologiques prennent plus de temps. Mais néanmoins, quand on regarde les volumes de consommation parmi les usagers déclarés, que vous voyez dans cette diapo, pour l'alcool et le tabac, on voit qu'il y a eu une nette majorité des usagers habituels qui n'ont pas augmenté leur consommation d'alcool et de tabac pendant le confinement. En bleu et en gris, vous avez la proportion de ceux qui n'ont rien changé à leur consommation ou qui l'ont diminué. C'est 89% pour l'alcool et 74% pour le tabac. Certains y ont même vu une occasion de faire une pause, de se mettre à l'épreuve, de faire le test de l'abstinence, en tout cas vis-à-vis de l'alcool, en l'absence d'occasion de sociabilité. Et puis alors à l'inverse, en rouge, on a ceux qui ont plus consommé. Donc vous voyez que c'est surtout le tabac qui a été surconsommé par rapport à l'alcool pendant le confinement. 27% des fumeurs déclarent une consommation en augmentation. Et parmi eux, il y en a la moitié qui ont augmenté la fréquence de consommation. 1 sur 10, le nombre de verres bu en un jour de consommation, et un quart à peu près qui ont augmenté les deux. C'est-à-dire à la fois le nombre de jours de consommation et aussi le nombre de verres. Alors, 2 commentaires là-dessus. D'abord, les raisons qui sont invoquées pour expliquer ce surcroît de consommation sont différenciées selon le produit. C'est-à-dire que les raisons mentionnées par les fumeurs sont plus souvent l'ennui, le manque d'activité ou le stress, alors que les consommateurs d'alcool qui ont augmenté leur consommation déclarent plus souvent que c'était par plaisir. Ça, c'est le premier point. Le deuxième, c'est que la hausse des consommations n'a pas touché les mêmes catégories de population, selon qu'il s'agisse d'alcool ou de tabac. L'augmentation du tabagisme, elle est plus fréquemment mentionnée par les jeunes actifs, les travailleurs à domicile et les femmes, alors que l'augmentation de la consommation d'alcool est plus le fait des moins de 50 ans, des urbains qui vivent dans une ville de plus de 100 000 habitants et des parents d'enfants de moins de 16 ans. Alors on retrouve avec le cannabis une structure de comportement ressemblante à celle du tabac. Globalement, la majorité n'ont pas changé leur consommation. Vous le voyez, quand on fait la somme de ceux qui sont en orange, qui n'ont pas changé leur consommation, et ceux qui n'ont pas du tout consommé, en gris, on arrive à 54%, donc c'est une majorité, même si elle est moins nette que pour l'alcool et le tabac. Malgré tout, ce qu'il faut quand même signaler, c'est qu'un segment des usagers a fumé plus de cannabis pendant le confinement. Et là, on a une hausse du même ordre que pour le tabac, de l'ordre de 27%, avec deux observations qui se détachent. D'abord, plus la fréquence d'usage était élevée avant le confinement, moins le comportement d'usage a varié pendant le confinement. Ça, c'est le premier point. Et le deuxième, c'est que les usagers les plus fréquents ont été les plus captifs du cannabis, en quelque sorte, c'est-à-dire que les consommateurs quotidiens ou hebdomadaires ont majoritairement maintenu leur consommation à l'identique ou l'ont augmenté, alors que le comportement était plus élastique chez les usagers les plus occasionnels. Donc pour résumer, tout se passe comme si le confinement avait eu pour effet d'exagérer les habitudes de consommation. Quand on consommait un peu de temps en temps, on a consommé encore moins. Et quand on consommait de façon régulière, on a consommé encore un peu plus. Donc la période de confinement, en quelque sorte, durcit le rapport au produit. De ce fait, la structure des usagers de cannabis a changé pendant ce premier confinement en surreprésentant les comportements les plus extrêmes, c'est-à-dire ne pas consommer du tout ou consommer beaucoup. Vous voyez que la population des usagers occasionnels, qui est en bleu et en vert, s'est rétrécie, avec l'hypothèse que les usagers les moins accrochés au cannabis ont vu dans la difficulté d'accéder à du cannabis par le trafic de rue un facteur dissuasif. Et puis en rouge, une partie qui a augmenté de part et d'autre du confinement, avec des usagers quotidiens qui ont été plus nombreux pendant le confinement. Donc le chiffre à retenir, là, c'est près d'un usager sur 10 parmi les usagers mensuels de cannabis avant le confinement sont passés à un usage quotidien à la faveur, entre guillemets, ou à la défaveur du confinement. Donc une frange pas négligeable d'usagers en situation problématique, ce qui fait écho à la notion d'usage problématique qui est mesurée par des échelles de repérage. Parmi les critères qui reviennent, il y a le fait de consommer seul et de consommer le matin. Et vous voyez que de ce point de vue, la part des consommations solitaires a augmenté de façon assez conséquente avant et après le confinement. Idem pour les consommations avant midi. Donc en fait, la moitié des usagers qui ont fumé leur premier joint avant midi ne fumaient pas le matin avant le confinement. Donc il y a eu des habitudes de prise. Alors je termine avec un focus sur les jeux d'argent et de hasard. 10 ans après la légalisation des jeux d'argent et de hasard en ligne, l'année 2020 a constitué un tournant dans la prévalence des pratiques de jeu. Vous avez ici la courbe des joueurs actifs par semaine. Vous voyez que sur les paris sportifs en rouge, elle s'est effondrée avec l'arrêt des compétitions sportives pendant le premier confinement, mais pour reprendre de plus belle et pour se retrouver aujourd'hui à des niveaux records. De la même manière, sur le poker en ligne, on a des évolutions qui sont moins marquées, mais là aussi, 2020 est une année record et on a dans les deux cas des prévalences qui sont beaucoup plus élevées aujourd'hui qu'avant le confinement.
If we look at the number of active players, gamblers per week, you see for online poker, it's twofold. So we see also an intensification of gambling practice with a higher bets, and the class of age is young adults. So there's a question of the risk of excessive gambling and the protection of youth and the online sports bets and the increase of the number of gamblers per day. And the last figures, they're about 1 million gamblers in the first semester 2021. So overall, the sales of online gambling increased by 200% to increase 1.7 billion euros, which is the highest level since the opening to the competition in 2010. Finally, to conclude, the successive confinements change the situation. The consumption modalities change. Now there is a daily use of cannabis among occasional users. We have to look at focus on that in the years to come, and also the semantic lines have changed with the introduction of the notion of a good of first necessity, which was considered as an essential goods, alcohol, tobacco, but also vaping products, such except countries like Belgium. And even if it's more rare, in states where cannabis was legalized, recreative use of cannabis was legalized, cannabis became a good of first necessity in 10 US states and Canada, which with easier access to cannabis, which remained after the lockdown with the home delivery, which is now possible in some US states, or drive-in or in the streets. So to come back to France, the lockdown period had paradoxical effects. For instance, it led to an expansion of the harm reduction policy with development of harm reduction in a distance. There is a transition with the following presentations by practitioners. I have 4 questions to conclude. At this stage, we still don't know much about the socioeconomic inequalities facing the risks of addiction during lockdown. For the time being, we don't have much. The second question is, during the period of lockdown, was a revealer of the tropism of public policies. The countries which were prohibitive for alcohol and tobacco strengthened these measures, and they prohibited the sale, when the more liberal states took advantage of this period to have more flexible, easier rules. You see that in the states where it was legalized. Finally, there was an effect on intra-family violence due to alcohol. It's a central issue. There is a project to look at this point, and more generally, we want to know what will remain of the living habits taken during lockdown. The results of the health barometer will describe the evolution in the use of cannabis. I don't want to spoil the results, but there was a survey of teenagers. Some experimentation did not take place. There were less youth had opportunities to consume because there was less partying. So for all these results, you can look at the OFDT website. Thank you. Thank you, Ivana. That's a lot of information. Some are surprising. Now we're going to give the floor to Joan COLOM, who's in charge of the program for harm reductions and also in charge of HIV, hepatitis, and MST. And he's a long-time friend. And he's in charge of this. He's been in charge of this program since 1987. So he's Joan, you have the floor.
Merci beaucoup, Jean-Pierre.
Thank you very much, Jean-Pierre. First of all, I would like to thank you for inviting me again to take the floor here. It is a privilege to address you during this event every 2 years. It is always a pleasure, and it's a pleasure to find my friends. Thank you very much, Jean-Pierre and ATHS, for inviting me here again. I'm going to speak Spanish because I'm not fluent enough in French to deliver a whole speech. So maybe you can use your headphones, your translation interpreting devices, if you want to follow the speech. So I'm going to tell you about a specific example of what happened in Spain and specifically in Catalonia during lockdown. Even though, well, Ivana was saying so many things that I don't know what to say, because most things are common. So this is what happened during lockdown. We knew that from March till May 2020, there was a complete lockdown of all activities. It was a total lockdown of activities. We were all very worried about what may happen, and this was an unprecedented situation. Never before had this happened. Schools closed, all shops closed, and there was a complete paralysis of any kind of economic activity. This is the Ramblas in Barcelona. This is the high street in Barcelona, and it was absolutely empty. So we just thought that we had to analyze and we had to dig in further. We really needed to know what was happening during this lockdown. And it happened from the 21st of April till the 22nd of May 2020. So we developed a health questionnaire in Spanish and Catalan in order to see the effect and in order to manage the impact and help decision-making processes. when it came to dealing with new programs. So the questionnaire had 120 questions revolving around 6 different items: well-being, emotional well-being, worries and concerns, habits and lifestyle, confrontation behavior, and social support. We had 37,800 respondents. They were major and they were mostly residing in Catalonia. And this survey was delivered in a Google format form. So we understood that the response may be biased because, well, maybe some people would have connectivity issues and then they wouldn't respond to the survey. Well, we had 74% of women responding, and 57% of the respondents had university studies, and 60% were employed. So we weighted out all these results so that they could become comparable to previous surveys. So what were the results of the survey? They were very important, and that's why I was talking about emotional well-being or emotional distress. Symptoms of depression, anxiety were increasing threefold. You can see here that there were 3 times more depressive disorders, anxious disorders, and emotional distress. So, of course, all this was compared to previous surveys that had been developed in the same way and using the same methodology so that they could remain comparable. And another thing that was striking was the increasing use of tranquilizers, sedatives, and sleeping pills. This was increasing threefold for all the prescribed drugs, but it increased tenfold for non-prescribed tranquilizers, sedatives, and sleeping pills. So you can imagine a tenfold increase. And who were the most affected groups? Well, basically, we're talking about young adults, students, women. These were the most affected groups, as you can see here. We can also see that within those groups there were significant differences, but these were the most important groups, and they were suffering twice as much of the risk of having a depression. And then we wanted to know how healthcare professionals were doing. So we wanted to see what was the impact of those HCPs who work at the primary health centers or in hospitals. And there we could also see a very important result, a very high result of disorders all related to anxiety. And then there was also another relevant group, and it's retired people. Now, for retired people, in spite of usually suffering high levels of depression, so we're talking about 20% or 30%. However, these retired people show less prevalence during lockdown than other professional groups and other age ranges. So this was actually drawing our attention. Maybe these people were more protected or they had less risk. So this is probably what happened. And this led us to think about some other points. 1 year later, in October 2021, The Lancet published a result which was really quite parallel to what we have found out ourselves, namely that the pandemic was making depression and anxiety skyrocket, especially amongst young people and women. They were the most vulnerable ones. Out of 3 cases, 2 of these cases affect women. So regarding the use of substances and addictive behaviors, as Mrs. Obranovic was saying before, during lockdown, we observed a significant reduction of cannabis use, whereas cigarette and alcohol use was remaining almost the same. But again, cannabis use was reduced. In spite of all this, 40% of usual smokers declared that they would smoke more during lockdown. So the great difference is actually whether you have been smoking regularly before or not. And 40% of people who were usual drinkers would drink more during lockdown, but not the others. Only 1% of the population who would use cannabis before lockdown referred increasing their use. So 99% of the population did not use more cannabis during lockdown. And it is quite curious because the perception of the population was not like this. You can see here the headlines in some media, in the press, during lockdown. You can see these headlines which say that alcohol use skyrockets during the first weeks of lockdown. We see this increase in beer sales and decrease in oil and toilet paper sales. So, well, there was a perception that alcohol would be more and more used, but this was not the case. This was not true. And on top of this, you can see here that there was an increase of advertisement regarding alcohol during lockdown, using social media and also somehow playing with COVID. You know, in some cases, we saw headlines saying that this beer or that beer would help you resist COVID at home. You may drink beer together because it may be interesting. So beer drinking would be surrounded by messages around resilience and pleasure if you were drinking during lockdown. So this is quite curious, and we had to manage this kind of news. And then there was another issue regarding fake news. In many cases, it was said that moderate wine drinking may protect you from the effects of COVID, and this was extraordinary. And these led the Federation of Spanish Wineries to say that wine would have palliative properties against COVID. And after that, the WHO issued an official communication saying that alcohol drinking will not protect you against COVID. And you can see there's this comedian in Spain. He's very famous, and he used his program, which is a program with a lot of humor, saying, look, if you drink a lot of alcohol, well, you will not kill the virus. You will increase your health risk. So, well, this was the kind of situations that we had to confront. So what was the situation regarding substance use and addictive behaviors? Well, just have a look. Narco trafficking, drug trafficking was reduced, access was reduced, sales were reduced, and of course, the use was reduced as well, because there was a lot of difficulty to access this kind of substances. And this is such an interesting experience from a sociological point of view, because as we had very well guessed, if you reduce access, you may end up reducing use. And this was proven during lockdown by many international surveys as well. This is, for instance, a survey by the European Observatory of Drug Dependency, and these were the results for Spain. So you can see that most people who were participating in this survey, declaring substance use of psychoactive substances, they declare having reduced the consumption. So we're talking here about usual users. And we see this reduction by 70%. especially in heroin, more in heroin than in cannabis. And the reasons for reduction are quite obvious. There's less access, less availability, less opportunities to use these substances. However, it was also shown that those people who were struggling and who had difficulties during this lockdown situation, well, there was the emergence of this kind of habits. For instance, the social drinker, when he's at home alone, well, maybe he or she faces problems to deal with this and ends up drinking more. Then we were comparing some healthy habits, and we could see that there was a worsening in most health habits and behaviors. For instance, there was an increase of the use of screens, not only online gambling, but because actually online gambling increased less, but the use of screens increased so much. For instance, we see a 200% increase of data use. All gaming consoles were sold out in shops, and two businesses like Steamy or Epic Games were selling out all their reserves. Now, what happens with online gambling? Well, as Mrs. Obranovic was saying before, this online gambling was plummeting because actually there were no sports activities, no horse races or basketball matches. However, casino gambling or slot machines gambling, these increased a lot during lockdown. And this was so that actually there was a bill approved in Spain in order to slow down, in order to stop this kind of advertisement during lockdown. So what were the main concerns and risk factors during that survey? Well, first of all, uncertainty. Uncertainty because we were facing the first lockdown, so nobody knew what may happen afterwards. And then there were problems, of course, with coexistence and living, in family, because not everybody has a large flat to live together, or not every household has a garden. We can see that in many cities we would have people crowded in small flats. So all this would add up to these factors. So that's why there was this increase of anxiety and depression. And sedentarism and the lack of physical activity were very relevant as well. We can see here that physical inactivity increased. Over 60% of the population remained seated for 6 hours a day. And you can see that before it was only 35% of those people who would do that. And then the average of hours seated was increasing by 2 hours. So from 5 hours to 7 hours. And again, the degrees of physical activity. And now regarding confrontational strategies and protection factors, well, we discovered with this questionnaire what the protective factors were. So basically, it was about having a good social support, following up a routine, even though you may remain at home the entire day, and just have some kind of time for yourself. So these made us make a kind of decalogue, a kind of list of good habits in order to have, in order to have a tool to confront the situation. And then there was the network for drug dependency care. We were making such an effort in order to adapt our attention services because, first of all these care centers were locked, but immediately after the declaration of lockdown, there were lots of programs that started, and we would connect with people online, so we could leave our care services open virtually. So this is what we analyzed by the end of 2020, we would have imagined that there would be such an important change when it came to treatment centers. But we see that there was a reduction of the beginning of treatments and hospital discharges. You can see, you know that in Catalonia we have 18 different injection rooms. And of course, access was reduced, but only in 12% of those rooms, which is really not a bad result. We were afraid that the situation would be even worse, and we were afraid of having many, many problems with the population of users, but we could really counter that bad situation very well. So we made some studies to see what the impact was among those users. We see here a study carried out in 13 different centers with 568 users, and it was mainly alcohol and cocaine users. So 1 out of 3 users got worse. Actually, yes, during lockdown, 1 out of 3 were using more drugs, and they also worsened their psychiatric symptomatology. And the ones who were doing worse were especially young people. They were poly users, and they would be drug injection users, and they would also show more psychiatric comorbidity. And we did the same kind of study in harm reduction centers. It was a qualitative survey on 40 different users with individualized interviews, and we found a similar result. Namely, there was that necessary adaptation to new schedules, to the use of new technologies. So this led to an adaptation, and of course it was not easy at the beginning, even for professionals, but everybody recognized that this was beneficial in the end. So, in other words, there was such an extraordinary response in front of those difficulties by professionals and by all the care organizations that the results were really good. And users, of course, they would complain about the difficulty to access some basic commodities, but we would provide the basic needs. For instance, we would use messengers, and we would use all kind of services in order to provide people with their basic needs. And this is an article published in the Journal of Harm Reduction, saying that, well, the same results, that the results go in the same lines, even 1 year after. I know I have 2 minutes only. Well, let's say that since this event is also concerning hepatitis, well, I've also got quite an experience in hepatitis, and there's this study showing the effects of 1 year lockdown in hepatitis, which is very much associated with drug users as well. Less than 900,000 people diagnosed, less than 700,000 more, 300,000 more deaths related to hepatitis C. No country with a 1 year lockdown, no country would have achieved the objective of eliminating hepatitis C by 2030. And you can see here another interesting study in the UK. Here we're comparing morbidity and mortality. And we can see that 17% more of morbidity is shown here, so advanced disease, and a higher mortality as well for hepatitis C. So this is the result of 1 year lockdown, meaning 1 year of underdiagnosing, underscreening of hepatitis C. So you can see the huge impact of COVID in other diseases. So that's why we made lots of recommendations for healthcare professionals and for citizens. We use social media as well, and we We also made recommendations regarding, for instance, gender violence, which was increasing a lot during lockdown, and the use of electronic devices as well, and people who would suffer alcohol use disorders. Here you can see the four waves. We're still missing the fifth wave, which is a Delta strain. But everything that I explained is happening here in this speak. In the first speak, which was, it didn't have the same magnitude as the following peaks, but it was just a surprise at the very beginning. So let me finish with a positive point. What happens during this kind of pandemic? You can see that the first wave is about confronting mortality and morbidity, which is the most immediate thing about COVID. The second issue is how to deal with urgent patients who are suffering the restrictions of access to health. The third issue is how to assist regarding chronic diseases, which have been underdiagnosed and undertreated during the lockdown. But the fourth issue is what we're dealing with right now. It's a post-traumatic disorder after COVID. It's the mental health consequences. And this is what we're facing right now. This is what is affecting us today. So let me finish, malgré tout, in spite of all, with a positive point. This was very popular in Catalonia and in Spain during confinement. Many balconies in houses, at 8 p.m. in the evening, people would get out in the window and they would clap hands for the healthcare professionals and they would sing songs. And this was the motto. Todo irá bien, everything will be okay. Thank you very much. Thank you. Thank you very much, Joan. Actually, we would need all this data and all these cutting-edge actions that Catalonia is putting forward. Now we're going to give the floor, if she is here now, we're going to give the floor to Mrs. Steffanie STRATHDEE. I think she's here, yes? Hello, Steffanie. So you're here on video?
Je suis désolée de ne pas pouvoir être avec vous aujourd'hui. Je vais vous parler de la prévalence et des corrélations de la séropositivité pour le SARS-CoV-2 parmi les injecteurs de drogue dans la région transfrontalière de San Diego-Tijuana. Tout d'abord, je voudrais remercier mes co-auteurs. C'est une étude internationale avec des collaborateurs des deux côtés de la frontière. Et ceux qui connaissent notre région.
It's situated on the Mexico-US border, and Tijuana is immediately adjacent to San Diego. So these two cities are about 20 minutes apart. By way of background, people who inject drugs may be at elevated risk of SARS-CoV-2, the virus that causes COVID-19, due to a number of different factors. For example, their living conditions. If people who are homeless or who have been incarcerated may be more likely to come into contact with people who are infected. It's also been speculated that drug-related exposures, for example, pooling resources to buy or use drugs or sharing drug paraphernalia, could bring people into close contact with one another because their addiction forces them to interact. And engaging in sex work could also predispose to SARS-CoV-2 infection because social distancing can't be practiced in sexual transactions. A study conducted in Baltimore and Maryland found that active substance users were less able to practice social distancing than former substance users. But to our knowledge, research on risk factors for SARS-CoV-2 infection among people who inject drugs has not been conducted. That led us to conduct our study to examine the prevalence and correlates of SARS-CoV-2 infection in our binational community-based study of PWID in San Diego and in Tijuana. We hypothesized a priori that SARS-CoV-2 seropositivity would be associated with crossing the border from San Diego to inject drugs in Tijuana, homelessness, trading sex, and injecting drugs more often. In terms of our methodology, we conducted this study beginning in October 2020 when it became safe to do so. And we concluded the data collection for this analysis in June of 2021, although this is an ongoing cohort study. The eligibility criteria were designed because this is actually a study to examine drug markets within the context of a cross-border setting. It was not designed to study COVID, but since the COVID pandemic began right around the time we were funded, we took the opportunity to do so. 3 groups of people who inject drugs began to be recruited in our study. All had to be at least 18 years of age and who have injected drugs within the last month. We included San Diego residents who had not used drugs in Mexico, Tijuana residents who had not used drugs in the US, and San Diego residents who had crossed the border to Mexico and used drugs in Tijuana within the last 2 years. And those are our drug tourists, as we call them. The data collected included interviewer-administered surveys done on laptops and testing for SARS-CoV-2 RNA and antibodies. We also conducted rapid testing for HIV and hepatitis C. And to examine correlates of SARS-CoV-2 seropositivity, we conducted binomial regression analysis. This study was approved by ethics committees in both UC San Diego and Xochicalco universities. So first, in terms of our biologic test results, we included 405 people in this analysis, and we found that 36.3% had antibodies directed against SARS-CoV-2. The majority of these were IgM antibodies, which suggested that the majority were recently infected. And of the 140 people who's tested positive for SARS-CoV-2 antibodies, only 37.5% had ever had a COVID test. Surprisingly, we did not find that any of our participants had SARS-CoV-2 RNA, so they weren't actively infectious at the time of data collection. However, more recent data collection has shown that this assay for detecting SARS-CoV-2 RNA does work, despite the fact that we were batching specimens. We have picked up recently more infections in a recent wave of COVID infection. 8.3% of our sample was HIV positive and 34.5% were hepatitis C positive. In terms of the socio-demographic factors associated with SARS-CoV-2 seropositivity, we found that older age and Hispanic or Latinx ethnicity were both associated with a higher risk of COVID. So for example, for age, for every increase in age is associated with a 2% increased odds of having SARS-CoV-2 antibodies. And we did not find that any of the other socio-demographic factors were associated with SARS-CoV-2 seropositivity. We also examined a number of substance use factors, and this included both non-injection and injection drug use. So for example, smoking, inhaling, or vaping, as well as in frequency of injection or visiting shooting galleries or using a hit doctor. None of these were associated with SARS-CoV-2 seropositivity, as you can see, because the 95% confidence intervals all embrace one. We also examined some structural factors that we thought could be associated with SARS-CoV-2. You can see that homelessness was not associated with SARS-CoV-2, but incarceration in the last 6 months was marginally associated with a higher risk, as well as engaging in sex work, which was significantly associated with SARS-CoV-2 seropositivity. We also examined preventive measures associated with SARS-CoV-2 seropositivity. We actually found that the vast majority, about 85%, had engaged in at least one protective activity, such as social distancing or wearing face masks, but only stopping smoking among current smokers was associated with SARS-CoV-2 seropositivity. We hypothesized that this was likely due to the fact that symptomatic individuals stopped smoking because they had trouble breathing. We also examined potential comorbidities that could be associated with SARS-CoV-2. such as HIV, Hep C, diabetes, asthma, and hypertension, and none of these were significantly associated with SARS-CoV-2 seropositivity. So developing a final multivariate model found after controlling for gender, that age, Hispanic or Latinx ethnicity, engaging in sex work, and incarceration were all independently associated with SARS-CoV-2 seropositivity. Incarceration was borderline significant, and sex work was the factor that was most strongly associated with SARS-CoV-2 seropositivity. Now, in terms of the interpretation, we can say that SARS-CoV-2 prevalence among people who inject drugs in San Diego and Tijuana exceeded estimates from the general population in either city. So they do appear to be higher risk for SARS-CoV-2, at least in our setting. We did not find that SARS-CoV-2 prevalence differed by country of residence, and it was not associated with cross-border mobility as we had hypothesized. And even among the lowest socioeconomic strata in the US and Mexico, we found that ethnic disparities in SARS-CoV-2 prevalence persist. For example, African-American and Hispanic ethnicity has been found to be associated with a greater risk of COVID. And so we found in our study that this was the case as well. About 60% of our sample was Hispanic, and we had too few African Americans to examine whether or not they were at greater risk. We did not observe any substance use behaviors to be associated with an elevated risk of SARS-CoV-2 infection, as others have hypothesized. We did find, however, that circumstances in the risk environment, notably sex work and incarceration, were independently associated with significantly higher SARS-CoV-2 risk of infection. Now, sex workers may have faced additional hardships that put them at risk of COVID in our study. The closure of the US-Mexico border, which began in March of 2020 and has continued until this day, has reduced tourism, which puts an extra strain on sex workers that are reliant on US and other tourists for their trade. And as I mentioned earlier, social distancing is not possible during sexual transactions, which could put sex workers at greater risk. And when we examined this further in our study, we found that significantly higher proportions of sex workers reported low or very low food insecurity, and or very low food security, that is. So they had unstable food supplies. And they were more likely to report having been exposed to someone that they knew who had COVID than other people in our sample. So this suggests that they really had to engage in survival sex work, where they felt that they were forced to engage in behaviors that would put them at risk just to survive. Our finding that recent incarceration was independently associated with SARS-CoV-2 seropositivity could reflect institutional exposures such as overcrowding. In fact, there's been great attention to this in the literature, and there have been reports in the press that during our study period, there were outbreaks of SARS-CoV-2 infection within prison and jail settings in California. This led the governor of California to begin to depopulate some of the prisons, but a subsequent study found that overcrowding persisted. So we feel that it's very important for these structural factors to be addressed in order to reduce risk for vulnerable populations. Limitations of our study included the fact that this was a non-random sample. It is unlikely to generalize to all people who inject drugs, and that low statistical power affected some associations, for example, incarceration. And we also found that some participants may have changed their behaviors as a result of experiencing symptoms. So the issue of reverse causality. So for example, people may have stopped smoking because they had COVID, that stopping smoking was not a risk factor for SARS-CoV-2 infection, for example. We could not examine the impact of COVID vaccination in our study because vaccines became available near the end of the study period in May of 2020 for May of 2021, for example, in the US and in June in Mexico. However, only 9% of our sample had reported being vaccinated, and this was supported also by the serology results. So this really suggests that this is a population that is in great need of vaccination. So in conclusion, we found that people who inject drugs in the US-Mexico border region are at high risk of SARS-CoV-2 infection. We found that social and structural factors were more important potential risk factors than individual level behaviors. And therefore, the onus of responsibility for change really needs to be on government and policymakers to make these environments safer. So, for example, decriminalizing sex work or drug use could play a major role in reducing risk, since we found that both sex work and incarceration were independently associated with SARS-CoV-2 infection. We found that most people who inject drugs in our study engaged in at least some preventive measures to avoid infection, but nevertheless, over 1/3 had evidence of infection. So this suggests that a binational policy response is warranted beyond the closure of the US-Mexico border, which we felt really didn't make any difference. There was no difference in seropositivity between the residents of the US or Mexico. The proportion of participants who'd previously been tested for SARS-CoV-2 or had received COVID vaccine in our study was very low, and there needs to be efforts to increase their uptake. As well, additional efforts are needed to reach the most vulnerable in this population, and this would include older residents, those who are Hispanic ethnicity, and those who are sex workers or who have been incarcerated. With acknowledgments, I'd like to thank the La Frontera study and our team, our participants in both cities, the National Institute on Drug Abuse for funding, and staff at both Genolite and Flexergy, which helped interpret the findings from our serology results. Our lab staff and a number of people who were very helpful in the terms of the design of the instruments and the preparation of this study. Thank you very much for your attention.
Bien, merci beaucoup Steffanie. Alors, j'étais un petit peu surpris parce que...
Thank you, Steffanie. I was surprised because I thought that we would have Steffanie in video conference, but she's here now. Just to be safe, for safety reasons, she recorded her presentation, and she is with us now. She will be with us for the discussion. So let me introduce her after her presentation. She came to Biarritz a few years ago. She's a professor and famous researcher at the University of California in San Diego. And she's been working for a long time on the risk behaviors and drug injectors in this cross-border area, which is very hot between San Diego and Tijuana. Tijuana, the legend. It's a complex city, difficult city in terms of drug use. With high risks. So thank you very much, Steffanie. And we're now going to listen to the other presentation. And after, we will have a debate. And we will be very happy if you can debate with us. Mary Joffre-Rousstide will do her presentation before the debate.
Thank you to the organizers of ATHS. Thank you for inviting me to present this data. I'm going to present now some data coming from two studies. First of all, the quantitative study, a global study, and a qualitative study between France and Canada regarding issues of drug use during COVID with a harm reduction approach. And the idea here is to show you an international perspective and how France is positioned regarding this compared to other countries.
Voilà. Donc, je vais commencer déjà par les données de la Global Drug Survey.
So I'm going to tell you about the Global Drug Survey data. This is an international survey that was carried out online. It's carried out every year on the general population, and communication is made via media. So we try to have as diverse media as possible to have a diversified sample. So between May and June 2020, together with the ATHS team, we put in place a COVID survey. So as you can see, this was supported by different partners. We were working with all these media, Libération, the Vice, also other kind of associations working with us as partners. So this is a survey that recruits a convenient sample, but we try to diversify the sample as much as possible. So we were surveying about substance use habits and psychosocial consequences of this substance use and during COVID, and the meaning of this substance use during COVID. So 20 different countries participated in the study. Analyses were carried out in 11 countries, such as France, where we analyzed the result of 6,000 participants.
C'est bon. Alors d'abord, je vais commencer par les données relatives à la consommation de cannabis.
So here I'm going to report on cannabis use. So you can see France here in yellow, and you can France is blue and other countries are in yellow. So what we can see here in the slide just confirms what Dr. OBRADOVIC was saying before, the fact that most cannabis users remain stable in their consumption during COVID. So we have more or less the same use also between France and other countries. Now, regarding stability, this is the data for cannabis use. However, for France, we have a more important share than in other countries who declared having reduced their cannabis use. So actually, we can see that this is the case a bit less than in other countries, but 20% of the sample report having increased moderately the use of cannabis and 17% having had a high increase in the use of cannabis. Now I'm going to tell you about the motivations for those users who said that they were using more cannabis. So the motivation was firstly a matter of time. And so motivations were very much related to boredom, anxiety, depression, and loneliness. So maybe we can discuss this afterwards, but when we compare French data and data from other countries, we had more therapeutic use in France than in other countries regarding cannabis. For other substances, we're going to see cocaine, and in the case of cocaine, we see that there's an important increase, and this is what happened. Actually, during the first lockdown, we see that for cocaine, at the beginning, there was a great reduction in the use of cocaine, and the same goes for ecstasies or party-related substance use. And in France, this reduction is even higher than in other countries. So we see the motivations for cocaine reduction So what we can see here is that the difficulties encountered to access cocaine are not really mentioned by users. It's not a motivation for them to reduce consumption. What really made them reduce is that there was less occasions for use. Users find they are less eager to use cocaine, and this is very much related to sociability and, well, social relationships when it comes to the use of cocaine. I would also like to report on benzodiazepine. We see in this case that France is, together with Brazil, the country where we see the highest increase in benzodiazepine use in the first lockdown compared to the 10 other participant countries. Motivations for the increase of benzodiazepine use is anxiety, distress, depression, isolation. So the trends of this global drug survey is that, according to the declaration of the participants, there is no major modification in terms of the availability of products that may lead to a change of behavior. Therefore, the change of behavior is rather related to a change in lifestyle or in life habits, meaning, in other words, that users have just adapted to lockdown. So there's a certain rationality of use. Users have adapted to the context, and they have adapted to the fact that there's less occasions for drug use related to partying, and the same for therapeutic use. So users report that they have increased their use because of loneliness and isolation, depression, anxiety. And this is actually also confirmed by another survey amongst the cohort of young people. We have carried out this survey between France and Canada. It's called Focus, and we were looking at cannabis use. And when we compare the use of cannabis in France and in Canada, French users said their motivation was mainly therapeutic during lockdown. So we see the reduction in stimulating products use, such as cocaine and ecstasy. And there's this French specificity regarding the increase of benzodiazepine use together with Brazil. So this was quite surprising in our international observers. Now I'm going to deal with the second study. This is an ethnographic study based on qualitative data. We have carried out this study with Karine Bertrand. Karine is in Canada, and I was responsible for France. And this is about the impact of COVID on harm reduction. So we will see the situation in Canada and in France. Now, I don't know whether we have talked about this term before. COVID-19 must not only be considered as a pandemic, but rather as a syndemic. This is a term that was put in debate, in discussion. When we talk about a syndemie, about a syndemic, it means that there are many different disorders that are going to come up together. So the pandemic will not only regard health issues, but it will also reveal a syndemic, namely also social consequences, poverty, stigmatization, cultural violence, gender violence. So this is going to lead to many more consequences. So it's important to bear in mind that COVID is not only a health pandemic, but it is a syndemic. So a pandemic having social consequences. So now, regarding the survey in Canada and France, Not only did it include the lockdown period, but also afterwards. So I'm going to show you intermediary results since the survey is still in course. We can see here that dependence and social precariousness would lead to a higher risk of infection and a higher risk of exposure to COVID. What's important here is that when we ask respondents, sometimes, and their users, sometimes they're surprised that they didn't get COVID in spite of their exposure. So actually, for some users, signs related to COVID would be very much associated to symptoms related to withdrawals or many other infections that they can catch for the fact of being homeless, for example. So there is an underestimation of the prevalence of COVID in this kind of population. Also, regarding harm reduction services, well, these services were disrupted in Canada because of organizational issues, but the pandemic showed that social innovation was still possible. So first of all, what was the reaction of professionals regarding harm reduction during the pandemic? There were two phases, and the first phase is still going on. We have to point out a very important commitment, a very important involvement by professionals during the first period of lockdown, because many professionals showed up in spite of not having the necessary protective equipment. Because if you remember at the beginning of the lockdown, not always did we have all the individual protection equipment, and many professionals just exposed themselves and took the risk of coming up to help. So actually, this is something that we observed, and what we have seen also in the study is that becoming adapted to COVID and facing adversity led to new forms of solidarity within structures with support networks. And there's a characteristic in France. There were very little care centers which locked down, which closed because of COVID. Whereas in Canada, for instance, injection rooms would close because professionals there would be recruited to work in other kind of services. So many professionals were displaced from their usual workplace to another kind of care centers. So they were assigned to different functions. And then there's a second phase that comes up after October 2020. There were situations of burnout amongst professionals. They are exhausted after the lockdown and after these very difficult situations encountered also in households. But again, professionals managed to leave their care centers open. Now, regarding social innovation, there's a very important characteristic in France, and it regards accommodation. Now, we see that in terms of social innovation, we're talking about the effort made by France to reduce this kind of weakness. There's a harm reduction model in France, which is very much focused in the biomedical aspects regarding replacement treatments, for instance. So we're very good at an international level when it comes to replacement treatment. But when it comes to rehabilitation, for example, we're lagging behind compared to Canada, for example. Now, with COVID and with lockdown, we were able to unblock different spots and different places in care centers in order to host users who were homeless. And So we were able to put in place some regulation measures for their use. So there were more resources, more money, and more care devoted to social rehabilitation, which was not the case before for us. Let's say that compared to Denmark, well, we were much less focused here in France on social welfare and social support than in other countries. So these support mechanisms that were put in place, and again, this does not spare us from inequalities, but I have to say that in different towns there has been an emphasis made in order to provide accommodation for these homeless users. So these allowed us to perform a good harm reduction policy. And this is actually what happened in the city of Paris regarding the use of crack. And we also interviewed people who would benefit from this accommodation services. We asked them right after lockdown, and for these people who were under very precarious situations, well, they were protected because of these new measures. Then there's another issue regarding harm reduction for alcohol in accommodation centers. So this was a taboo subject, and now the fact that there was this social innovation and the fact that we could discuss about this alcohol risk reduction in accommodation centers, this is very much related to the intention in France that was put up in the 80s for drug users. There was a lot of tension between harm reduction and withdrawal. So when it comes to alcohol, well, it very much illustrates that situation and that tension. And we saw that during COVID, we could really reflect on harm reduction beyond that opposition that we would encounter before regarding use versus rehabilitation. So this is what came up in the first interviews that we carried out with Karine. We really put the limits further. And regarding social innovation, there was much more flexibility when it came to access conditions in order to access injection sites and to avoid people going to the black market to get their drugs. And there was another important difference between France and Canada and the United States, because I would like to say that this study was also carried out in the States. Now, this very large access allowed us not to face a wave of ODs, whereas in Canada and in the States, well, these two countries were confronted to an increase of overdoses. And this access to replacement therapies was more difficult for American users just because they have a health system which is very difficult from very different from ours in France. There's very little public funding in the US, so lots of care centers would have to close, and many users were left aside, actually, with no access to treatment whatsoever. So we see that in France, this harm reduction policy with a large access to health services has allowed us to mitigate a very likely trend to overuse, to overdose. So, conclusions. COVID-19 revealed the strengths and weaknesses of each model. So now what really is to be underlined here in France is that there is public funding, so important public financial resources devoted to harm reduction, and this has facilitated the continuation of all those services and care centers. Another strength in France is that these financial resources are provided by the state, and therefore there was less territorial inequality in France than in Canada. And in France too, and this is not the case in Canada, we have a care and prevention system which is very well structured, and it depends very much on important associations. So the health system in France is well structured, and this has allowed to resist COVID and addictions. And in spite of, as I said, all those professionals who were displaced from their workplace, so we still had some territorial inequalities. And in France, we have very important intermediary structures, such as associations and federations of associations, which have been lobbying in front of public authorities in order to provide care, in order to provide attention. Therefore, the system could evolve and could remain in France thanks to these intermediary structures. Now, when it comes to perspectives, I have shown you so far intermediary results for the surveys and for our study. Now, there's a committee for protection of people, and we're going to put in place another survey. This time it's going to be the Cocolico survey. And now for this purpose, we could benefit from funding by the ANRS. So we will be able to perform the survey such as the one that Steffanie just showed. So we will have an estimation of the infection rate amongst users, vaccination rate. We will test with biological data. We will have biological data that will allow us to have these statistics. And we will collaborate with the Addictions Federation, which is still under construction, and we will see how our services are organized. We will have a qualitative and quantitative part of the study. And there's also an international group on COVID-19 and harm reduction, which has been put in place since April 2020. So it's 18 months ago, and we're working together. And this project is spread in 15 different countries with different researchers. Shushan Naranovich and another American, Helen Hansen, who are both American, and then Caroline Parker from the UK, and myself. So in this project, we're going to carry out an ethnographic study to see the impact of COVID in harm reduction and the experience of users, with the perspective of criminalization also. And we will have a special issue of the American Journal of Public Health with paper and case studies published. So if you want to access the data by this Global Drug Survey, GDS, this has been published in Psychotrope. Thank you very much. Thank you, Marie. Thank you very much for giving us this international background. And I would like to say that, well, now we're going to start the discussion after these introductory presentations. And so let's move to the discussion.
So we'll have half an hour for the debate. Jean-Michel, do you want to react? Thank you, Jean-Pierre, and thank you, the ATHS, to invite me to this inaugural session. And the presentations were remarkable. It's interesting for field actors like us, like me, in Bordeaux, to listen about the feedback at the international level in Europe, in Catalonia, in California, in Canada, in the States. Of course, I would like to thank Mary to highlight this from a researcher, that addiction care worked well in France during that period, so we can be happy with that. If some hospital services, because of redeployment, had to close down for staff reasons, but the XAPA, the CARUD, and the residential XAPA remained open, and they were able to provide major care and emergency care. Just a memory about the beginning of the first day of the first confinement. Bordeaux was empty, and I was going to one of the CARUD centers in Bordeaux. I was surprised to see many people, users, drug users, some were injecting in the street, and they were distressed because they had no food, no money, and no water. Everything was closed, and they were asking me for food, hygiene kits. So our services had to change, and it was really frontline social services, and based on that, we were able to continue developing harm reduction actions with a promotion of harm, remote harm reduction. In XAPA, we exchange by video and by telephone with the patients. The major change in an emergency was the access to opioid substitution, because we thought that with the scarcity of the medication, that people would store, and there would be variation and increased risk of overdose, as Mary said, for some states in Canada and in the US. But with the reactivity of the health authorities, we were able to deliver prescriptions by mail, by fax, and the pharmacists could renew the prescriptions. So we were able to maintain the supply, the substitution supply during the first month of the lockdown, and even to increase it. And this was due to an increase of the methadone more than buprenorphine. Therefore, we know that the figures are more or less stable. The increase of overdoses was limited to 20%, if I may say so. And during the Canada, they were saying, and English speakers were talking about 100, 150 or 200% increase in some states. So there was a beneficial effect. All this, and back to the speakers, remind us that addictions are a global issue. It's not only a medical problem, a social problem. It's an integrated issue that requires a global response. I liked when Mary said, she talked about Richard Orton, about the current episode. Remember the memories of Singer during the AIDS pandemic. Is a convergence between epidemics and other disorders, psychiatric disorders, addictive disorders, and psychosocial vulnerabilities. So it's among these populations that the problems are concentrated: behavioral disorders, violence, overdose risks. And maybe this is where all the presentations agree, because I was Stephanie's work in San Diego, because Michel Lemoine and myself were at the Scrip Institute for many years. So I don't know Tijuana as much. Is this violence a legend there? But Stephanie's work showed that much more than the practice of drug users, what determined the risk of over risk is to be infected is the social conditions. It's the incarceration, etc. So I have a question for Steffanie. Based on that, what are the proposals to support, integrated support we can provide for the users, especially from a social point of view, support, housing, besides a psychological approach?
Thank you very much for the opportunity to join this discussion. I've enjoyed the presentations, and I just wanted to comment too. As a Canadian, I was happy to see Marie's presentation and pointing out that it's important that countries provide financial support in the context of a pandemic. But as you could see from the presentation that I made, when you have individuals who are incarcerated, or those who are sex workers and sex work is criminalized, they are not able to receive the kinds of supports that other members of our communities receive. So if we decriminalized sex work, for example, then sex workers could avail themselves of those social programs. If we decriminalized drug use, then we wouldn't have drug users incarcerated in very close proximities where they would be exposed to one another. So I think it's important to have this broader lens that many of the presentations touched on today, that these social and structural factors are really driving SARS-CoV-2. We've seen it for HIV, we've seen it for hepatitis C. These are syndemics.
Merci. Je pense en effet que la décriminalisation, la dépénalisation.
Thank you. Yes, I think that the criminalization of the drug users and the sex workers are the next frontier in harm reduction. Back to Joan, there was something that struck me is a psychological aspect. The data you presented on Catalonia and Spain in general were very close to the ones we have in France. Earlier, Ivana mentioned COVID-PRED had a sentimental aspect. It was a very large sample, and we realized that after the first lockdown, the prevalence of the depressive syndromes and anxiety went up to 20%. Normally, it's 10%, so it was a twofold increase, and the care demand increased by 30%. So there is something like a syndemia. There are psychological vulnerabilities of addictions. I know that in Catalonia, you work a lot on dual pathology. What can you tell us as a way to develop this integrated approach, which are not just at the beginning in France now?
Yes, we have incorporated different projects in order to improve this intervention. For instance, we have developed home-based care program for primary care, and a very important program, so that all people with important problems, well, they can receive this care at home. And then we have developed another project, which is called the KIA project, with professionals of psychiatry, psychology, pedagogical professionals, for children as well, in order to screen post-traumatic distress or emotional distress that may have been caused by the pandemic, by all the issues that the pandemic has led to, that we are witnessing right now, but also in the future, because there's quite a challenge when it comes to manage all these problems. And we really need innovative ideas. We need community-based interventions. We need to do outreach. We need to get the problem at the root. And something else that we have witnessed during the pandemic is that there's a need for some residential care for users. This is what you call auberge in France. In other words, some spaces that will allow to have harm reduction risk policies that are implemented, including alcohol. And what I would also like to underline is that the care structure is going to change. It's already changed somehow because there's telemedicine, there's artificial intelligence, and of course, all these things are there not to prevent human contact, but rather as a tool in order to increase adherence. So this is all the kind of initiatives that we're developing in order to improve the situation. And I would really like to underline the huge effort of our healthcare providers, because in France, in Spain, they have been really involved so much in their work that actually we could not even see any kind of reduction in the service that they were providing. So these were very important adaptation. And actually, I would like to say something else about telemedicine. Telemedicine has been, of course, support, but of course, it cannot replace the clinical and the human contact. I would also like to say that, yes, we have to point out this post-traumatic stress disorder. We worked with the International Federation, we worked with the Addictions Funds in order to propose that in 3 different regions in France, we can develop experiences regarding psychotrauma in order to identify innovative experiences and also in order to develop that at a national level. We were surprised to get these 3 different possibilities of funding. And, well, this will allow us to do a bit more of harm reduction. A second point that I would like to stress, and that was a source of inspiration during COVID, was this kind of community-based approach. People who would just turn to people who were vulnerable, and or people in the street that would be supported by other people. So we're talking about vulnerable people with a lot of psychosocial distress. And we saw that it was via a team group made of social workers, but also people from associations, that we could really support those vulnerable groups. So actually, right now, we have called the national authorities in order to promote this kind of structures, to accommodate, to support vulnerable people. And Marie was also mentioning this, the alcohol harm risk reduction. This has been a historical fight, and thanks to all the work that has been carried out by the associations, just like Santé in Marseille, we see that we are again reaching this harm reduction in alcohol as well, which used to be a blocked access in the past. So people would have never imagined before that they would find a site where they would be accommodated and they would be hosted. So I have questions for our female researchers here, Ivana and Marie, who were talking about social inequalities. And Marie was telling us how important this was. So how are you going to do in practical terms in order to approach all the problems? And Ivana, what are the projects about? Because I think that this is a major issue that you were talking about. So in order to respond to this project, Project Coquelicot, we're going to measure this social inequality dimension of COVID, even though we're talking here about a population that is globally precarious? Well, the co population is namely users who go to harm reduction structures and addictology centers and all the tools that are related to harm reduction and treatment. We're going to spread our Coquelicot project in 27 different cities. We're going to work in 5 different languages, so we will study a diversity of situations. So we will include migrant population who do not speak French. And regarding social inequality, we're going to collect the data that Steffanie presented, but we will also add data taken from experiences of discrimination, also data regarding the country of origin of the individual, but also their ancestors, their parents and grandparents. So this will lead us to qualifying certain ethnical differences. We will also dig in the issues such as access to accommodation, experiences with police, experiences with trauma. So this is the kind of data that we will collect in order to measure social inequalities. And we're talking of a population that is quite precarious. It's a population of users. And so regarding social inequalities, our survey will be carried out amongst the general population, namely adults from 19 to 29 years old. This is a cohort. We will deal with, and it will be financed by the ANR and also by a Canada Institute. And we will see the social inequalities. And social inequalities have proved to be a factor aggravating COVID. And there's also another study in France saying that the most infected people were poor people, because they wouldn't have access to prevention measures, or they would live in smaller houses, so the exposure was greater. So there has been quite a lot of research regarding this, and all the data is collected and is being published. And there will be more data soon enough. And we will qualify from now on the data from a more ethnographic perspective, as I was saying before, bearing in mind all those different aspects that I mentioned. And we will also include aspects like criminalization in order to study whether the level of criminalization in countries has a relationship with COVID.
Then I wanted to ask Nicolas, but if you have a question, go ahead. I will quickly answer. We defend a mixed method, quantitative approach, or qualitative approach. For the time being, what's we're doing now through the health barometer, where we rework for the adult population and for the young population. This next edition will be in 2022. We would like to integrate the specific questions with, for instance, among the young people, questions on police checks and on the social characteristics of the youth. That's something we don't measure much for the time being, which will be related to the retrospective issues on youth behaviors during lockdown. And at the same time, we're going to launch a series of quality studies. We're now building our work program for the next 3 years. And we're going to have a part on the care pathway, on how people getting out of who stop smoking. And we're going to see how lockdown affected these pathways and what's the part of the social aspect or the gender, and we're going to diversify our samples to try to look at the territorial inequalities. We haven't mentioned it earlier, but overseas we don't have much information, much data, whether qualitative or quantitative. So there's something we can develop there. Nicolas? Thank you again. I agree with Jean-Michel. The presentations were remarkable, and it was a real pleasure to hear your points of view. This COVID crisis reveals social inequalities. That's obvious. You all highlighted it. Another indicator is the increase of tuberculosis in the world, which is, again, it reveals how this crisis is exacerbating the social inequalities in health. The conclusion for all this is let's develop integrated programs. We need to have a long-lasting solution. We need to develop programs to promote health that take into account all these indicators, all these health indicators, which go beyond the substance use. It goes through psychosocial skills, education, housing, etc. We need funding, governments to invest in these programs if we don't want to go through such crisis again. A few words come to me when I listen to you. Structural. I think there is in this crisis something very structural. The physical structures as such, their role, their opening times at night, at different moments, which were related to curfew, lockdown, etc. Structural in the sense where some structures changed their mission. The shooting gallery started housing people. Parisian colleagues said how they housed the users in the restroom, in the shooting room, and at night how they worked with the harm reduction, how the carrot started producing gel, hydroalcoholic gel. And in the structure, there is also this aspect of this human resource aspect. They were changing. We had them, we didn't have them. People living in France, they had to stay home to babysit. So new organization charts. So there's a real structural issue within the structures. Also, another issue with numbers or digital access to products through digital resources, access to deliveries by calling different telephone numbers, access to equipment. And we see really how the digital is being used more and more. But there is a major movement going on. A third aspect in the digital is communication, information or misinformation, disinformation on alcohol, which protects from COVID, or tobacco, or disinformation. We saw that in the last 2 years in the media, and masks that you have to wear, but they don't work, and gel. So for a time, we were really, we had problems with information. Another element is a financial economic aspect. There's something around that. It's almost a financial crisis, this COVID crisis for the users. Something around the products, stocks, their regulations, supply and demand, the prices going up and down. Some have access to goods, others don't. Some users were stocking up for the lockdown. And Ivana, you said that also the pressure, the financial pressure, the restructuration of the market, different elements that bring to my mind a financial crisis in a liberal economy. And through all this, the last point, it's the social inventivity, as Mary said, with the community resources that developed, that community resources that remind me of this book, Pandemopolitik, which reminds us of in other countries in Africa, Asia, we have developed other types of community protection measures from COVID. And we should, these community movements were good protection measures. I have two additional questions. The first one is how in the social innovations, what is the place of the user? How is it different now? And if it has changed, how can this change be in the long term and be sustainable? Sustainability of the place of the user, its skills. I think this occurred in many structures during the lockdown. The users developed many skills. Is this going to last? Can we strengthen it? And second question is more practical. Mary, you talked about a decrease in the consumption of cocaine and benzodiazepines. Other cocaine users, it's not easy to consume cocaine by yourself. It means that they transferred their consumption to other products. That's my question. For the last question, very short. For cocaine, the reasons why they stopped consuming cocaine, it's because there was no socializing opportunities. It was very low for availability issues. I think that to relate that to your other question, to answer both questions very quickly on the role, the place of the users, one of the lessons of COVID is we talked about structural adaptation, but the users adapted, they developed skills, and they used COVID to stop in consumption when they had access to housing, for instance. But there was really in the interviews we had, some users mentioned the fact that COVID, like in the general population, was a time for them to stop and to make a change and in the long term. One sentence. I have a question for the room. It's just one sentence. By the end of the year, we're going to come up with some trends, and it's mostly the cocaine users that we have seen less in the public space by definition. This confirms the results of that study.
Okay. Maybe one question, if you may, or not. All right. Fair enough.
We strongly hope next time you could be with us in Biarritz and you could travel and to stay. Très bien. Merci beaucoup. Et
à la prochaine.
À la prochaine. Bye bye. Et donc, merci à.
So well. Thank you, and thanks to the participants who would rather come here instead of going to the beach to enjoy the weather. So we will resume tomorrow at 9 a.m. Thank you.